And this is not an exaggeration. This is not a lie. I wrote this in my journal because I came home that day and I was like, holy fucking shit.
Right?
I gave a patient 256 milligrams of oxycodone in a 12-hour shift. If I even took a 26 of what you're taking, I'd be on the floor.
200. Homeboy was a tank. Yeah. I mean, lady, she took it like a champ.
Yeah,
Better to have a short life that is full of what you like doing than a long life spent in a miserable way.
Hey. Welcome back, everyone. Thank you very much for joining me. My name is Swadik Mayanja. You guys can call me Q, and we are on another episode of the Everyday Hero Show, where I bring to you someone in your life or someone in my life that brings us joy, happiness, and good things, but does not get the credit that they deserve. This week, we have a superstar podcaster. She's a nurse. She works night shift. She does a lot of things for the community, y'all. Show us some love. We have Adrianne from Nursing Uncensored on. Thank you so much for joining me, Adrianne. Welcome.
Hi, I'm so happy to talk to you. This is really cool.
Oh, good. This is good news. This is good things, y'all. This is good things. So I'm going to just start off right away and just tell you, Adrianne, you have a very, very soothing podcast voice. You get that a lot.
I do get that a lot. I used to also work in a call center in my days long before I ever worked in healthcare, and I got that a lot. But you know what? Sometimes I get worked up on the show, but for the most part, this is like my mid voice, and then I even have a more soothing voice, the therapeutic voice that comes out like when I'm trying to talk down a patient that's like anxious or like super pissed off. So there's even a deeper level of relaxation than this. So I like it. I always feel weird about it. I'm always like, oh, okay, I guess. But yeah, enough people tell me that I'm like, all right, that's cool.
No, I really love the voice. And like I've been listening to a few episodes of Nursing Uncensored, and I'm like, every time I'm like, wow, this is I want this voice to whoever my nurse is. I want them to have this voice. It is fantastic.
Thank you. I hope I'm not putting people to sleep.
Stop it. Oh my God. Stop it. So let's talk about real quick origin story. I want to know how you ended up becoming a nurse. What was your pathway to becoming a nurse?
Yeah, I actually just recorded like an episode about this because I've had a few people ask me recently, when did you go to school? How old were you? Like, because I was a non-traditional student. So essentially the short version of the long story is that I was selling car insurance in a call center. I was not happy. And a friend of mine who knew I wasn't happy said, hey, I've been doing home care. It doesn't pay as much as your insurance job, but I have freedom. I really like the people that I help care for. And so I applied for that job. I got that job. I did, it was home-based care for adults and adolescents with both varying levels of physical and mental disabilities. And I did that for 2 years. And midway through that,
nursing, so home care, like nursing assistant, like,
but essentially, yes,
home health care.
Yes. And so I got to have experience with patients that had like spinal cord injuries and stuff like that. And so I was emboldened I was like, well, I'm doing this in people's homes. Like, why don't I level up and like do this for like a job, not just like something I was doing in between because I was unhappy. So I applied to the hospital in my area. I had 2 interviews. The first one, I was so excited. I'm sure I sounded like a manic, crazy person because I was so like, yes, I will be amazing. And I think I needed to dial it back a little bit. So I didn't get the first job I interviewed for, but I got the second job I interviewed for, which was in neuroscience inpatient unit. And I now lovingly refer to it as boot camp for CNAs. Because, I worked
boot camp for CNAs, huh?
Yeah, because it's an intense floor. It's an intense patient population. You have people that have, and we're a level 1 trauma center. So, we have people that have had bilateral cranioplasties, like they're missing bone flaps. They're extremely sick, have a ton of recovery to do. And so after I did that full time for like 3 or 4 years. And then a few times I had been floated to another unit, and it was very different vibe. Didn't have that kind of like, pardon the phrase, the balls to the walls feeling of like, I'm doing everything as fast as I can. And then as soon as I'm done, I start all over again. So then I worked there for so long, and I saw so many nurses that I was like, I think maybe with the right training and education, I could do this. And then started a very long process through school that was kind of riddled with obstacles. So essentially, I'm doing this podcast now because while I fell in love with nursing podcasts in nursing school, none of them quite hit on the material I wanted to hear about. Like, there are great nursing podcasts about patho, growth in your profession, pharmacology. Like, there's all these really great episodes that focus on kind of I want to say the technical side of things. I wanted to hear people talk about kind of the soft sciences of being a nurse, not just like, oh yeah, there's some role transition, but I wanted people to know that in some jobs, that anxiety is real, that fear is real, the excitement is real. And so I started with a couple friends. I was like, hey, like, let's start talking about this stuff. Let's record it. Let's put it up and see if anybody gives a shit. And so we did that. And there were several times when I almost quit. I was like, nobody's paying attention. Why am I doing this? This is stupid. What have I got to bring? But now it's been 2 years and it's growing exponentially, and I'm getting letters and people are saying, hey, your voice is great, your content is great. And part of me is like, awesome, yes, that's what I'm trying to do, like I'm hitting the mark. But then there's the other part of me that has this like crazy amount of imposter syndrome, and I'm like, oh no, really? You like it? Oh, I can't believe you like, there's that part of me that's not just trying to be modest, but like I really am kind of like, really? Like you listened to that? You were inspired by that? Like, yeah, that's what I wanted, but I didn't know I'd get there. So yeah, that's kind of how I went from working in a car insurance call center to being a nurse. It took me a long time to do it, but yeah, that's kind of how it happened.
Yeah. That's a story. That's quite the story, Adrianne. Yeah, you going up and down, left and right.
Yeah, because I have friends and coworkers that are in school, and they're like, this is not the journey I thought it was going to be. Like, this has taken some turns and curves.
Yeah,
it does that. It looks different for everybody. Some people do it straight out of high school. They know they want to be a nurse. They hit up nursing school. They get it done, and they start their career. I was 36 when I got my nursing license for the first time. So, I can't say that I have any regrets, but damn, do I wish it hadn't been such a hard path,
I hear you. And that's the thing. So I luckily for me, I kind of knew coming out of high school that I wanted to do nursing, and then I jumped into nursing as soon as I could. But so I want to know what your transition was like from the visiting nursing to the actual facility. You said it was neuro, right? Brain injury, trauma, stroke. Mm-hmm. Because the difference is huge, right? I feel like it's going from 0 to 100. I feel like that's a huge leap. Usually people jump into med surg. Maybe you want to jump into even a nursing home, a nursing facility, because visiting nursing is a very specific. If it's not a hospice situation, it's like I'm there to, just turn my patient or just like get them to the bathroom, wash them up, make some breakfast. Mm-hmm. How did you go through that, right? And I want, what was that process like? Because dealing with one patient and all your focus on one patient to going to a facility and them telling you now you have 7, 8, and I know you're an aide, so sometimes 12 patients.
So
how did you function? How did you get through that and still decide after going through that huge leap, I still want to be a nurse?
Yeah, it was a huge difference because when I did home care, I started out working in essentially in an apartment. They had 3 people that they had kind of paired together with personality and whatever else they used to find people roommates in this particular home care system. Yeah. So I had 2 patients. I shouldn't say patients. I'm so used to saying patients. I had 2 clients that were ambulatory and had some mental and mild physical disabilities. And then I had the one client who was quadriplegic, needed full cares, like needed transfer. So I had kind of, you're right, I had done it with one person. I was like using a lift, I was using gait belts. I had to be careful of like injury and safety and all that. And then going to a 48 bed unit where sometimes you're one of two CNAs. Ideally, staffing would be like 4 to 5 CNAs on a heavy inpatient unit by my hospital standards. But sometimes it was like you're on night shift and it's like somebody calls off sick, they don't have somebody else to send. Honey, you're running. You got 12 patients and 6 bosses. Or I'm sorry, 24 patients and 6 bosses. So it's different. I don't remember it as crisply as I do now. It's kind of been muted by nursing school, which was the real kind of struggle for me. But I do remember days that, I cried before going to work. I cried coming home from work, either because it was so hard or I was so exhausted. So it was a tribulation, but also I was able to keep up. And I was actively investing in my learning. And because the nurses there, it's a teaching hospital. So we have some level of like, there's an expectation that if you work there, you teach there, even if it's just like a student or an orientee or a coworker. So I had a lot of great nurses that were like, hey, under my supervision, do you want to do this straight calf? Like I've taught, you've learned sterile technique. You want to come in and just do it, and you're being supervised, everything's safe, everything's, sterile and clean. But I had these nurses that were willing to take the chance on me, be like, hey, you're in school, come do this with me. And I took every opportunity that was offered to me. Granted, made sure my work was done first and that I wasn't leaving patients hanging. But it was intense. It was incredibly intense.
Good for you.
Yeah. Well, and
you got some good people with you. Got some good
I
nurses
do.
around you.
I have, and there's always that one or two people along the way that you're like, oh man, you're trying me. You're trying me. But for the most part, I've been incredibly blessed to not have been bullied or initiated or however you want to say it. So, for any of my coworkers, past or present, that are listening, like, I hope that I express my appreciation often, because I wouldn't be doing what I was doing if it weren't for like the community of people that helped raise me.
I love that you say that, because I swear to God, like every nurse knows, every healthcare provider knows, like some days you're racing. I mean, like it is nonstop, right? It is hardcore, especially if you work in an acute care facility. And I don't like to brush off other like nursing facilities, but it's different.
It's different. It's just different.
It's just different, right? So everyone has their issues, right, or their struggles. But depending on who you're nursing, your group is, your team, your unit, that the vibe, whatever that team unit's support system at the hospital or has the facility is, it can make or break everything. Okay, so Adrianne, you call your podcast Nursing Uncensored. So there's a list of things that I have that I think that nurses we need to talk about some shit. Some real shit. Adrianne, we need to talk about some shit, okay? I mean, get some shit off my shoulders here. And your podcast is called Nursing Uncensored, and I went through a few of your podcasts, and you do touch upon some touchy subjects. I want to start there, and then I'm going to end on the touchy subjects that you haven't touched upon yet. Because it's super important, okay? Yeah. I just did a story for my Nursing News, a weekly podcast show, YouTube channel, about how nurses are at a higher risk for suicide than many other professions. I think when I found out these facts, I was like, holy shit, this is crazy, right? And I was like, in my personal experience, I've heard of one nurse in my hospital that has committed suicide. It was a really sad thing. We did everything we could for the family, but it was like every other suicide. It was out of the blue. Like no one knew, right? That's the thing. But I was so confused. I did the research and I looked up all the data, and it was just like, it's a lot of nurses who work night shift that are higher risk. A lot of nurses who are doing the 12-hour shifts. People think it's easier because you have 4 days off, but it's a lot of stress all in one day, squeezed in one day. It's a lot of nurses because all they're doing, especially when they're doing the overnights or they're doing the 12-hour shifts, are drinking 3, 4, 5 cups of coffee a day. Like it just, the schedule, the job, the emotional stress, the pressure, all of it gets put onto these nurses. Can you please talk to me about how do you deal with the stress? How do you deal with the burnout? Like, the fight against
That's a good
burnout.
question. Yeah.
And have you dealt with any nursing suicide issues of friends, colleagues, coworkers, any of that?
So to answer that last question, first off, I have not known anyone personally that I know of attempted or considered or committed. Here's the thing. That's the other thing is committed suicide. I've talked about this with my partner. This is like kind of a passive way of talking about it, and I think it also pathologizes it in a way that's maybe.
What do you mean by pathologize? I'm sorry.
So I guess here, let's say they committed an act. It sounds criminal and punitive. I personally, while some people may think it's insensitive, I say that person killed themselves. It was an action that they did. It doesn't mean they're a criminal. It doesn't mean that it means that they were in pain and something was unable to relieve their pain. And as
I gotta say, that does sound a little more heavy, and it makes you think about it a little bit more.
It makes you think about it more. It also makes you think about, like I said, like committed suicide, I don't know. That just sounds to me like something that would be on a police report and not, so anyway, that's like a whole separate topic. I don't want to go down that road, but I guess I have known nurses that have shown signs of burnout, including myself. My first 2 years, while I did not approach the realm of feeling suicidal, the tumultuousness of the stress and the continuous witnessing of suffering, the lack of self-care that some people miss out on, like drinking the coffee but not the water, like not sleeping well, not balancing work life, not having those coping mechanisms, whatever they are.
Yes.
And so it's taken me years to develop those, because I also do, on our unit, we do a lot of end-of-life care and palliative care or symptom management. So we're seeing people that are at the end stages of their diseases and are dying frequently on our unit. And some people bowed out. They were like, when we opened our palliative care service, they were like, I didn't sign up for this. I can't do this. I have kind of taken to it because even though, and here's the thing, it's taken me a long time. It's not just like, oh yeah, I'm good with it now. Like I still struggle. But just to mention a few of the things that have kind of made a difference for me is, one is, you know who Z-Dog MD is, right?
Of course, yeah.
Yeah. So he has a series of videos about empathy versus compassion, and how empathy can be a paralyzing and dangerous force when you are constantly exposed to people that are in suffering or in distress or in the worst time of their lives.
Wait, seriously?
Hospital. Yeah.
That's his take on it?
Well, so here's the thing. And
I feel like that's the opposite. Wait, what?
No, right,
seriously?
but it seems counterintuitive. But here's the thing, and I'm not going to try to distill down his message. I want people to go and listen to it. But here's the thing. So I think, and I hope I'm not messing up the metaphor, or not the metaphor, the example, but he talks about how, okay, say you have a patient that is detoxing from drugs, and you feel empathy for them. So empathy is putting yourself in their shoes, feeling what they're feeling, wishing you could relieve that suffering. That's kind of a crude, I mean, I'm sure it could be defined better, but essentially you feel what they're feeling. You want to make them feel better. So an easy way, maybe short term, to help someone who's detoxing from drugs is to give them the drugs they're detoxing from. If somebody's coming down from something that they've been addicted to, the empathy makes you say, I want their pain to stop. I'm going to give them the drugs. Your compassion, the side of you that is compassionate in the face of suffering, says, I care about you and I want you to be better long term, so I'm not going to give you the drugs. You're going to throw up. You're going to feel like shit. You're going to need meds to get through this. That's hard. It's hard to witness. It's hard to enforce when people are saying, please just help me. This hurts so bad. So this is a crude way that I'm distilling it down. I'm probably not doing it as eloquently or as in depth. I encourage people to find it on YouTube and listen to it. But if we act with empathy, we're going to burn ourselves out because we're feeling what they're feeling fully. We're putting ourselves in their shoes. With compassion, we're understanding what their situation is and we're feeling human love for them, whatever that looks like to you. But you're not going to give in just to relieve their immediate suffering. Does that make sense?
That's a perfect analogy or example, just because when you are dealing with, especially in nursing or in healthcare, when you are dealing with people who are using or who are dealing with addiction of any kind, their family, their best friend, the loved ones who are 1000% the enablers care the most, which you have to I mean, it's just the truth of the situation. The person that loves them the most is the person that's running to the store, getting them another 6-pack, is the person that's buying the drugs, borrowing them $1,100.
Often, yes.
And it's the worst thing, because you're like, you love them, you care about them, but you need to stop helping them because they don't want them to feel that's such a good example. Adrian, you're good at this.
And you have to consider, but it's taken me years and tons of like listening to other people, listening to podcasts, talking to other nurses, having them support me in my dark hours. And I try to remember that. I try to remember to have compassion and not empathy, because empathy will singe your roots immediately. Like, you can't do that for very long, especially when you're in a situation where people are suffering, people are dying. On night shift, we don't have as much support staff. We're much more autonomous.
Preach.
Like, am I going to call the doctor at 3 a.m. for this, or can I handle it myself without order? You know, like, can I do this without needing to cross over like my scope of practice. So that's one thing. The other thing is that I try to remember, like, for example, say I have a patient who has family and that patient is dying or they're sick or whatever, and the family's in distress. I need to remember that I may have my own grief, because sometimes I take care of patients that I've known a really long time. I see them from the early stages of their illness all the way through the end. So I have to remember, this is their experience. I may have emotions about it, but I'm a facilitator of this experience for them, whatever that means, whether that means pain management, comfort, you know, being the person that like sits and talks to them in the middle of the night because they're scared. That takes a lot of different faces. But the bottom line is that I can take care of my shit when I get home and I debrief with my friends or my coworkers, or I go to yoga, or I get on a bike and I ride my heart out till I'm exhausted and I can sleep. Like, whatever your coping mechanisms look like, you have to find those along the way. But the way you find those is by talking to other people. Hey, what do you do when you feel like this? How do you deal with it when you can't get something out of your mind that's been bothering you that happened at work? It's never easy, and it's never a perfect fix. Like, you're never going to handle every situation perfectly, but it's taken me a few years. But now I can say that if I have a difficult case, I may be tore up inside, but I know that I need to be clear and focused for them. And then if I need to lose it in the bathroom later, I can do that. But right now, this is their experience, and I can't. Like, I don't want to be crying so hard that the family member's comforting me, because then I've stepped out of my role and I'm not doing what I need to be doing for them. So, that's kind of how I think about it. But you also have to have those things that, like, if you don't have something in your life that you love that makes you feel good, you need to find it. Whether that's, like I said, all the things I listed: running, cooking, talking with friends, painting, whatever the hell it is you do, therapy. Find something that works. And when you find something that works, stick with it. If it stops working, find something else.
Right. I love that. Because we all need that something, right? Mm-hmm. We all need that something. I do want to talk to you about the end of life care for a lot of patients and how you deal with that process, right? So it's in the same ballpark, especially when you are talking about the empathy versus the compassion. Mm-hmm. But I think now that more states, I think we're up to 11 states now that has okayed assisted, what's it called? Doctor assisted suicide. Is that the term?
So I don't, that's kind of a charged term, I think. And I'm not the expert on this, but I think it's like there are death with dignity acts where, yes, if you want to boil it down, it is physician assisted suicide. Yes. But again, it's like, how do we temper our political and emotional conversations about that, and how do we make it like scientific, like how do we? So I don't technically know what each of these states calls it, but yes, there are many states where under certain circumstances, and if you meet certain criteria, you have the option to take medication that will end your life.
Yeah. So in many of these states, like, it is super intense. It's not like, oh, I'm having a bad week, like, let's go doc, right? You have to have a prognosis. The prognosis must be like you living less than 6 months. It has to be like legit. It has to
Some
be
of them,
legit.
You have to be a resident of the state for a particular period of time. So it's not like, oh, hey, I found out that, I'm sick. I'm going to move to Oregon and next week I'm going to do this. Like, it really, they do build it that you, it's just like with, like, for example, we also take lung transplant patients. You have to go through screening for that. Like, are you emotionally and mentally stable enough for this? Are you, so, you know, you have to think we are always kind of uh, assessing, how do I want to say this? I'm kind of losing my train of thought here because I'm taking too long to make the point. But basically, with end of life care, you have a whole different set of skills. Some of our
Yes.
patients, like I said, are end of life. Some of them are just there because they're receiving treatment and their symptoms are so intense. We can do things with medications that other services may not be comfortable with. Like, I've had patients that like are oncology patients and they have like intractable nausea, and we do a series of kind of off-brand or dosing that maybe other floors or nurses or doctors aren't comfortable with. So we have to learn like a completely different way of caring for these patients in an inpatient setting. And then you're running from one room where you have a patient that's full code and needs intensive cares and is very sick and wants to survive this. And then you're immediately walking into the next room and you have to change gears because people are mourning, and it's a more tender care, and you're not doing intensive rehab. And it's different to kind of flip back and forth. It takes some time. But this is where the community comes in. This is where, if I see that we have a float nurse on the floor that looks like she's terrified because she has an end of life patient, I go, hey, I don't want to be pushy. You might be fine. But if you need some advice or coaching on how to medicate, because sometimes we get orders where we're giving Ativan every 15 minutes.
Yeah.
Most nurses on most floors are like, oh my God, I'm going to kill
That's
that
insane.
person.
Exactly.
No, you're not.
You give when it
You're
needs to
giving
give.
them what they need.
Yeah. When I forget what the score is. What is it? What's the scale that they use?
Which, I mean, there are lots of
when they
scales. Which one?
detox it, because that's the one you
like,
pump.
we use the CWA scale.
Exactly, the
Yeah.
CWA. For us, like
Yeah.
in the beginning, I was the same way. I was like, it tells you to do the CWA as often, and like if you are supposed to give it every 15 minutes, every 30 minutes, you're like, am I really? But yes, you are really supposed to.
And I'll tell you this: the most. So I have 2 records. The most I've ever personally given a patient that was alive, well, at times alert and oriented. Once I gave a palliative patient with intense pain. I gave, and this is not an exaggeration, this is not a lie, I wrote this in my journal because I came home that day and I was like, holy fucking shit.
Right?
I gave a patient 256 milligrams of oxycodone in a 12-hour shift. And that patient was still having pain. They were not drug seeking. They had a legitimate diagnosis that was incredibly painful. And he was alert, oriented, conversing. And I was like, if I even took a 26 of what you're taking, I'd be on the floor.
Yeah, I'll tell you. For those who not understanding, what I mean, like usually you give it 5, 10, 15 milligram
like
tablet,
every 4 to 8
exactly.
hours.
So 200. Homeboy was a tank.
Yeah.
I mean, he or lady, she took it like a champ.
But when you have nurses that aren't used to that, and you come up and you've got orders to give, 1 milligram of morphine every 30 minute as PRN, exactly. And then you have these nurses.
They're asking every minute.
Yeah. We also, so I've kind of lost the initial question, but it's a very different world. So you have to kind of flip your head back and forth.
Before we move on from that, I wanted to know your personal beliefs on this. Your personal stand.
So here's where I feel. A long time ago, I would have said, absolutely not. This is not how we operate as a civilized society. But then, you know something? You watch somebody writhe in pain after you've given them 256 milligrams of a chemical that's supposed to kill pain. And you see people go through these things for months and years. I had a patient years and years ago that I remember his face, I remember his name, I remember the conversations we had, and he had ALS, Lou Gehrig's disease. So essentially, you basically, from the feet up, he started losing functioning in his body. And when you get to a certain point, you lose the ability to breathe too. And that's why, as a pulmonary nurse, I take care of ALS patients. You see people with these illnesses and disorders, and it's literally just like watching a freight train come at you. And you see these people suffering and making sound, they're of sound mind. And they say to you, I've had people say, I don't want to do this anymore. And I say, I hear you. I get that. I personally no longer feel that it is immoral. I think that it is immoral to not have a Death with Dignity Act, because these people already have to go through so much criteria. It's not like the death panels, like we're going to be killing grandmas left and right so we don't have to spend money. That's not it. That's not how the system is built. That's not, there's intensive screening. And then if anyone has ever seen the documentary, I can't remember, I think it's called like How to Die in Oregon. And it follows I'm getting chills, goosebumps even talking about it. There are these people that this woman says, she has a terminal illness, and she makes the choice with her family to get this bottle of medication that at any point she can drink and it will end her life. But she says, now that I have this bottle, now that I know I can control my own fate and stop myself from dying in excruciating pain and misery, now I feel like I don't need it. Now I can spend that time with my family. I can focus on being with those I love because the control has not been taken away from them. They don't have to worry about dying in misery. And to be very graphic, like, people are like shitting themselves. They can't get out of bed. They can't eat. They're in pain all the time. We can't give them enough medications to take away their symptoms. Until you witness that day in and day out, I don't think you have, I say you, but I just mean in general. I don't think people have a solid understanding of what it means to have a terminal illness. And I think that those more and more states nurses need to be going to bat for this. If you believe in this, you need to be pushing legislation. You need to be talking to, the governing organizations in your state, because while some people may be screaming at the computer, hell no. It's not until you hold someone's hand and they're begging you to end their life because they're in so much pain. And that got real deep real quick, but it's true. And
it's very true.
And as a nurse, you have to be able to go home and find that thing that lets you then shed it and let it go. Because if you hang on to that, you're not going to survive.
And I'm telling you, like for those people who don't know, and if you're telling me that, like, let's take all of these assisted suicide laws, legislation off the books, like, let's get rid of all of it. You have to understand that when you are a nurse and you see the total opposite of that, instead of helping someone die, have a peaceful, lovely, wonderful death the way they choose, the opposite of that is keeping everyone full code. And when you see a 90-year-old grandmother who and they code and you have to jump on top of their chest.
As a nurse, you're like, I'm going to crush you. I'm going to crush you beyond belief for no reason.
Exactly. Just so we could break a rib, you could get pneumonia, you go back into the ICU and die vented. Right. It's like seeing the opposite of like allowing the patient to go the way they want and just making sure we do everything we can 24/7 for every single patient. Like it really ends up being a no-brainer, right? It ends up being a no-brainer.
But some people take a long time to get there because everybody has their own experience and their own morality and their own, religious or spiritual beliefs.
So can we talk a little bit about that? I know I'm talking about real downy things, but we're going to change in just a hot minute. But
sure.
How do you deal with when you're taking care of a patient and it's obviously their time to go, but the family is asking, and the patient's nonverbal, the patient's dementia, they're confused, whatever the situation. How do you guys deal with the situation? And have you ever had to take anything to the ethics board where the family is like, we want everything. We want every tube, every vent, every measure, everything. Is that something that you've dealt with? And how do you go
So that does happen, and I've seen it end a lot of different ways. I've seen family members eventually come around and say, like, I understand, I see that they're suffering, I see that but sometimes it takes people a long time to get through to that. I know that in my hospital we have an ethics committee.
Yes.
And they are very active and involved, as well as I think our physicians, especially our palliative care team, they consult with teams throughout the hospital. So we're trying to make it so that palliative care is available to everyone. But you see a lot of patients, by the time they come to us, if they're full code, and there are times when the nurses are like, oh my God, this is going to go to shit. I just know it is. And I hope it's not on my watch. And you feel like you're passing a hot potato. And, at times you try to do education with the family and say, like, in very tactful ways, we can't fix this. I can only manage this for a time. Like, you want to have those conversations wherein you say, I'm about to hurt her in doing this wound debridement, this therapy, this physical therapy. This is going to hurt. And they can't decide for themselves right now. So I'm counting on you to be able to recognize together if the hurting is going too far. And sometimes it's hard. Sometimes people don't listen. Sometimes you can bring in the ethics committee, you can bring in other nurses, the physician, and sometimes people are just, they're not in a place where they can hear it. They're not ready, they're not willing. Sometimes you're treating your patient's family members as well as the patient, because, like I've had patients that have been actively dying for days. They've been nonverbal and, they like move their hand a little bit and the family member's like, oh, is she going to recover? Should we take her off? Should we take her off end of life care? Like, she squeezed my hand. And it's like, well, then to kindly and not cruelly explain, well, that's a reflex. And putting your hand in someone's hand is not meaningful motion. Now, if you say, hey, let go, and they let go, that
That's
indicates choice and consciousness and the ability to act on it. So it's really hard when you have people that are suddenly like, oh, she said a word, she opened her eyes. And in your head as a nurse, you're like, well, this might be the final rally. Like, we can't change the underlying pathology that is, it's a tough situation. I don't know that I'm giving a good answer to this, but you need
it's the only answer you can give.
Yeah,
it's rough,
it really
right?
is. And you need to, and that's when you especially rely on the coworkers that you trust, that have done this work. I look to my senior nurses a lot.
Yes.
Hey, what would you do in this case? I've even had new nurses say to me, this family member is intense. I don't know how to answer their questions. I feel like they're running me through the mill. And I'll go in and I'll say, hey, I heard you had some questions. I've worked here a long time. I really just wanted to make sure, your nurse, I never throw the nurse under the bus. I never say, oh, well, your nurse is new, so she doesn't know, so I'm talking to you. Because then they're going to be like, well, you just be my nurse. Like, then forget that person. But really what you need to say is, this person, your nurse recognized that maybe you guys aren't communicating well on this, and she or he wanted to make sure that you had this information. Or like, if I have a patient that's like, a nurse that says, like, I need you to come in and help me go through this, I say things like, as I'm just going to pick a name, as Jenny told you, these are some symptoms that you can expect to see. As Jenny was trying to demonstrate, or like what Jenny's been doing supports what I see, which is this. So I try to not only give my patients and their family members confidence in their nurses, but if that nurse is like, holy shit, I need help, I try to step in, because I do have the soothing voice, the therapeutic communication. That's something that I happen to be good at. I've never been involved in a code though. So if you need somebody to like jump on the chest, I might be kind of like, for a second, I would react, but that initial reaction might, whereas with end of life care, if somebody's like, hey, I need help talking to this family member, I'm like, I got you, boo. I'm in, I'm down. I can do that. But I think that kind of philosophy, as well as the whole philosophy of this podcast, is that every single nurse, whether you've been on the job a day or 100 years, you have something valuable to bring, because maybe you read an article that another nurse didn't read, or maybe you had a patient that another nurse has never had before. You can be a nurse for 40 years and you can get a case that you've never seen before.
Exactly.
All of this is possible. So I think
which is kind of the exciting part about nursing. I mean, it is super
exciting. It is.
Nursing
everybody has something, and everybody has something to bring to the table. You are bringing things to the table with your shows, talking about these hard topics, really polarizing topics. I thought you were going to ask me about the nurses that were charged with manslaughter during the hurricane.
Oh, yeah, you better believe it.
That's
are you in Florida?
No, I'm actually in the center of the country in Iowa. We are a landlocked state. But I have a friend that's in Florida right now as we speak. Yes. So I pay attention to these things. But,
so we'll get there, but I do want to switch.
You're providing a service too. So
thank you. Thank you, Adrianne. I appreciate that. It's good to hear. So no, but so on a different, let's flip this, right? Because it's nursing school. It's just back to school season. So I want to talk about nursing school, right? But I don't want to talk about, you've got enough information. I scrolled through your episodes, right? But the most recent one, you talk about the roller coaster of nursing school, right? And And it is so true. So I don't want to rehash anything you did say during that the podcast. So everyone, if you wanted to hear a comprehensive look at what nursing school is like, not
and
talking
part
about
two coming this Monday. So
oh
part
shoot,
two of that episode is coming out. So there's more roller coaster. There's 2 roller coasters.
There's 2 roller coasters. What's it called? So if you want a comprehensive look at it, and I'm not talking about the details of like, I mean, they do. You guys actually do talk about like getting homework done and like setting all that stuff up. But like, I'm not talking about like the actual science behind what does this med do or what does that disease process do. They talk about the generalities of nursing school. But I want to talk to you about that, the tension between nursing students and nurses, nursing, like, I have had the smoothest sailing once I became a nurse. I found that I had the most tension with other nurses or like people in the profession while I was a nursing student, during clinical, during my rotations, with my nursing professors. Everything seemed like there was so much tension all the freaking time, right? And it is a totally different switch from your prerequisites to being a nursing student. It's like the whole critical thinking aspect, all of that stuff is very, very heavy. But I have not been more stressed in my life than being a nursing student, which is crazy to say that day to day I deal with dying patients. But nursing school was the most stressful thing for me. Can you just talk to me a little bit about that entire process?
Oh my gosh. I will say, like I kind of alluded to, I was a non-traditional student, so I had a little bit more up and down of the roller coaster. But the whole reason I started Nursing Uncensored was because I didn't feel like people were talking about that moment of like, you start nursing school and you go from taking like your prereqs and you have homework and like it's good. Like you can manage, you have to work hard, but you can do it. And then you get to nursing school and you have multiple classes, labs, clinicals, your job that you may or may not be working, the fact that you have to, eat, sleep, poop, see your family.
On top of all of the nursing. When does this happen?
Yeah, right? And really all you want to do is lay down and go to sleep. Because in your waking hours, even if you're only in class, it's like information pounding. It's like being slapped in the face constantly with information. And then on top of that, so like now if I go in to do, like say I go in to straight cath a patient and you use sterile technique and you have to watch your sterile technique. If you break sterile technique, it's on you to make sure that you get a new kit and you start over so you don't get that patient a UTI and you don't get them septic. It's your process. When you're in nursing school, they give you, I don't know, I assume all schools do this. They give you like the list of steps in order, but it's micromanaged. You get a point for everything or a point off. You have to knock on the door, introduce yourself, wash your hands. These are things that we do subconsciously every day with every patient. And so when you're being tested of like, okay, wait, do I knock on the door and then wash my hands, or do I wash my hands and then go in the room? And so you start to like, I think that's where my anxiety as a new nurse came from, because I was like, oh my God, did I lose a point because I said the wrong word? Like, did I push the wrong button on the IV? Was I supposed to hold it like this? Was I supposed to hold it like this? Like what? You become so hyper focused because someone is watching you and they're like, oh, your pinky finger touched outside that sterile, and you're like, oh God, oh. So I think that there is this level of like panic that happens when you get into nursing school and you realize that you're not just like a student that's learning, but you have real people on the other side of the, eventually that's why they start you off on the fake arms,
right,
and like the dummies, like, because eventually the stakes are going to climb. And so from the first lab where you're like, oh my God, I don't have, that's the other thing is like, you don't have, it's like a hairdresser. You have to know how to hold a bunch of things at once. And so those things that you don't have as a nursing student become stressful. Like I'm fumbling.
Finger dexterity is something you learn. You have to learn.
Like how do I switch syringes without like having to scrub my hub again? Like I've got it down to a science. So I like joke with my friends that are hairstylists. I'm like, we should have like a contest on like who can do the most shit.
More. Yeah, that would be interesting.
But you have this transition, and the stakes are higher, and you don't want to have to repeat these classes because they're so fucking hard in the first place. Like, really, forget about it. I had a classmate who had walking pneumonia for an entire semester. They ended up failing that semester because, well, they had walking pneumonia. They were doing clinical, they were working, they were doing classes. That person failed that one class, so then they make you repeat the whole semester. She had to repeat 180 clinical hours in like her semester. So she did that twice. So essentially to
rough.
get her nursing degree, she did like close to 300 clinical hours when the rest of us just did it once through. So there are high stakes. And you think to yourself, "Oh, I got a bad grade on that exam." That's when you start calculating, "Okay, I can miss this many questions on the final if I want to like continue
Exactly.
moving forward." There's all this
It's
pressure.
so much stress. It
People
is
that are like, "Are you
so
done with
much
nursing school
stress.
yet?" And you're like, "I don't even want to tell you how I'm doing." So that role transition from prereq student to nursing student is huge. And I do think it's harder because once you get into your job, you don't have that person that's like, "You didn't wash your hands for 15 full seconds. You only did it for 12 seconds." Like,
Right.
okay,
Relax.
yeah. We all need to stay on top of our game, but I do think it's very different. And I think that students aren't warned about it. And I don't think nursing school does an ample enough job warning you about how you're going to feel when you get out of the clinical, out of the lab, and now you're in patient care and you have nurses that are in, that's the other thing I wanted to say. In my own hospital, I've never had any nurses that were bullying or treated me crappy or like didn't try to teach me.
Nothing.
Not at my hospital, but
Good for you.
I've done clinicals at many other hospitals, and I myself, as well as my classmates, have had that nurse that's like, she doesn't let me touch anything, she doesn't let me do anything, she doesn't let me see anything, she acts like I'm annoying, she goes into rooms without telling me, like I feel like I'm chasing her around like a puppy, and now she's more annoyed because now I'm like asking if I can do. So that does happen, and I'll say this concisely because I think I've touched on this a little bit within an episode. First of all, if you have a clinical instructor or a preceptor or a nurse that you're following that is bullying, it can be scary as a student to speak up because you're surrounded with that nurse and her coworkers and you don't know where their alliances lie and if they're going to throw a student under the bus. But if it really is bad, you don't deserve, even as a student, you don't deserve to be treated like shit. You don't deserve to have your learning infringed upon because they won't let you do anything. If they have concerns about your performance and your safety, that is the responsibility of the nurse that you're following or your clinical instructor to address, okay? But if you're not doing anything dangerous, you're not being a cocky, arrogant student, then there's no reason that you should be treated as anything less than an actively engaged student. Not all hospitals like that. Not all nurses sign up to be teachers. Sometimes they come in that day and they find out they've got a student.
Right.
But I say, suck it up. You might get a patient you don't like. You may have to talk to a doctor that's mean to you. We all have to do things that are unpleasant. So why make it worse for somebody else?
Exactly.
So I say to those preceptors, tell them you don't want to precept anymore if you don't want to do a good job of it. And if you're a student, don't take abuse and don't take shit. But if you have to go and say, "Hey, my preceptor," like I wouldn't recommend going in and being like, "Oh my God, that person sucks and they're mean to me and I hate this and I want to know." But go in and say, "I have concerns. This is how I've been feeling. These are the things that have made me feel that way. And while I'm happy for any opportunity, this opportunity I feel is like not right for me, or it's not working, or I'm not learning, or whatever." Hopefully your school is receptive to that. However, I also think that it's your responsibility as a learning student that you show up prepared, you show up proactive, you show up to ready to communicate with your nurse and your patients. So I think there are responsibilities on both sides. But don't ever let someone make you feel like you don't belong there or you are treated like shit or you're abused, or like I've had students that have emailed me and been like, "I heard the staff nurses like talking shit about me and my fellow students." We came around a corner and came face to face with them like as they were saying shit. And
That's rough.
And it's a case by case. Like I can't just say, "Oh, well, you should immediately go." You got to go to somebody you trust. Don't gossip it all over your clinical group. Like just keep it to yourself. Be responsible about it if you want to have your claims heard. Don't just like be inflammatory and yell and say you
throw
want
shit in the air.
Right. Don't talk about how horrible the nurse is. Like, don't do that. Just say, "This isn't a fit. This isn't working. Like, this is how I've tried to make it work. It's just not working." I was able to switch from someone that was treating me. They weren't treating me badly, but they weren't really giving me the time of day. And I was like, I'm paying money to go to this school, and I don't really, even though I'm not getting paid at this clinical, I'm not paying money so that I can have someone make me feel bad and not teach me anything. Because then I'm going to graduate and I'm going to have a whole semester where I didn't learn shit. So be proactive.
Advocate for yourself as well.
You've got to. And if you see your coworkers talking shit about a student or like not teaching them or like leaving them behind, say something. Hey man, you want me to take that student in when I do my meds? Because it seemed, be nice about it. I get kind of snarky when I talk about stuff on the show, but just try to remember. Sometimes we forget that feeling of being new and being the new kid on the unit and what it felt like in clinical.
It's really scary. I mean, it is scary as hell to walk into a hospital and be like, all right, first day clinical, you guys going to pass meds.
Like on my unit, we're a monitored unit. There are alarms going off.
Yeah.
Lights going off, people coming up to the desk. It's like stimulation.
You don't know anything. And people asking for you. It's crazy. It's crazy. It's crazy. But so a crazy thing, right? So a couple of months ago, I don't even know, it could have even been a year, but this blew up in the nursing community, right? The nurses about playing cards, and everyone and their mother was upset. Everyone and their mother, like, and I am the guy.
Don't come for nurses,
right? I am the guy that tries to do videos on all the hot topics that come out, and like I like to speak and like at least have my voice heard on these things. But I didn't say nothing. Adrian, so working night shift, I don't want to say there's downtime, but there's time where not.
Here's the thing. I'm gonna be totally honest with you. Sometimes, not often, depends on where you work. Sometimes the hardest part is working against your body's natural rhythms and staying awake. You might have a chill night, but then you've got to be alert. You can't be like
exactly
at the nurse's station. So you're like focused, alert, charting, making sure people are okay. Because you could be like dozing off, playing cards at the nurse's station, and suddenly there's a fucking code. And you're on it. You're up. You're active. So I'm not going to lie. Sometimes we have nights where I'm like, oh my God, I'm so bored. And then, of course, everybody's like, don't say that.
Right? You can never say it's quiet.
No. But also, like, some day shifters on those nights that are like unicorn nights where everybody's cool, everybody's asleep, everybody's comfortable, your patients are good, the alarms aren't going off very much. And some people are like, how the hell do you guys do this? Like, people are like doing stairs and like walking laps on the unit because they're like, I am gonna fall asleep. Right. Sometimes that's the hardest part, but for some people, that's a deal breaker.
Exactly.
I mean, so it's different for everyone, but most of the time, the great majority of the time on my unit, you don't have nights like that. You have nights where you are short staff. You don't have my unit, we don't have licensed practitioners. We're a step down unit, so we have patients that sometimes are like a hair away from going to the ICU. Like they could be in the ICU, but we can manage them. We take vented patients. Like we do all sorts of intense shit.
You take vented patients?
Trach to vent. We don't do ET tubes. We do trach to vent, and sometimes they're fresh trachs. We take patients that are 3 days out from a full lung transplant. Like we take sick patients.
I'm praying for you, Adrian. I'm praying for you.
That's just it. I do want to say this because I haven't really had any other opportunity to talk about this. I had my first rapid response as a nurse the last time I worked. I've been a nurse 3 years. I said I've never seen it. We've had plenty of codes on my unit. I've never been present for one. Knock on a lot of wood. I've not been present, but I had my first rapid response. And it was terrifying because in my head, I was like, it was a patient that had respiratory issues. They had a lot of secretions. We were doing nasopharyngeal suctioning, getting loads of crap out. Couldn't keep the guy's saturations up. So we get to a point where we're suctioning, we're adding to the oxygen. He's already on like 60% oxygen. He's only satting in the 70s. And in my head, I'm going, oh, should I call the rapid response? Should I do it? Do I need it? Should I just call the doctor? And I don't know about other hospitals. Like our rapid response is like the team that you call when you need more hands on deck. You're not at code emergency yet, but like you're getting there fast.
Something's going off.
We someone to respond. They send like the ICU. They send a doctor. They usually send the
respiratory
nurse
therapist
supervisor RT. Yeah, we're fortunate. We have RT on our unit 24.
Oh yeah, because you're pulmonary.
Yeah, so we couldn't. Oh my God, the breathing treatments alone would take us all fucking night. So we're lucky to have RT. But in that case, I was like, do I do it? Do I do it? Should I do it? Am I going to get in trouble if I do it? And I was like, fuck it. This patient's only satting 70%, and we're bagging him on 100% oxygen. Fucking call. If they get mad at you, oh well. And you know what? By the time the team showed up, I think we had knocked a mucus plug loose with like the intensive air force of the bagging. The patient was fine. We were able to clear some secretions. By the time the team arrived, he was sat in 100%, and he was back on his original like 40 or 30 or 40% oxygen, which is still a lot because he's still really sick.
Of course, he's in the
hospital. But the team said to me when I was terrified. I was like, oh my God, I hope this was justified. Like, I hope this was okay. The team thanked me. They said, he's done this before. And it was way more of an emergency last time this happened. Like, I don't mean he's done this like he did it, but like his condition has manifested this way before. They were like, you did the right thing. You caught it earlier this time. Now we don't have to worry about intubating him because he was intubated at one point for this same thing. So the doctors, thank God, they weren't jerks about it. They're not like, he's fine, let's go. They were like, thank you for calling. Thank you for recognizing that this shit could have gone sour real quick.
Oh, yeah.
And that harkened back to something that one of the nurses I interviewed, she's an ICU nurse, she said, because I asked her the question, how do you develop the balls to speak up when you know something needs to be done? And she basically, the short version of her answer was, once you speak up a couple times and you're right, that fuels your fire to want to go to bat for your patients. And you know what? If you're wrong, woo, you were wrong. Suck it up. Someone's not dead.
Right.
Like, you are not being wrong. You're being wrong is less of a consequence. Deal with it. If they get pissed off, like, this was totally fine.
It's life. Move on.
Use the services you have available to you.
You're not gonna ever lose your license for calling a rapper that's wrong. For calling a code blue that's wrong. You might lose your license if you don't call. You might lose your license if you don't call for help. So yeah, I would be wrong all day.
Should I? I feel like I should do it. Maybe I should do it. Should I do it? I was like seeking permission because I'd never done it before. I was like, no, I call the shots for my patients. If if the hair on the back of my neck is standing up, I now know that I can listen to that. So that's a good thing for newbies to hear. Like, even as a student, if you see a nurse that's about to do something super fucked up and you don't speak up,
yeah, like, what are you doing? Like, you
have
to say something.
If
you're
a
mandatory reporter, it comes with the job.
Yeah. So I just want to empower people to be like, if that's what you think you should do it.
Adrianne, you do have a little bit more time, right? I'm not.
Yeah.
Am I squeezing you? Okay, perfect. So I want to talk about now another. Like, of course, I have Nursing Uncensored with me. I'm going to talk about hot topics all day, all night. But can we talk a little bit about race and gender?
Yeah.
Like healthcare, right?
Mm-hmm.
So you have a patient. The patient says, "I would rather a male nurse," right? Or you have a patient that says, "I would rather a white nurse." Do you think those two things are the same?
No. Because I think that, for example, if a female says to me, I prefer not to have a male nurse, in my mind, I think, okay, I don't know if she has some kind of sexual trauma. I don't know if she has an abuse history, if she had, whatever. But for me, when it comes to race, like, the color of your skin isn't affecting the care I'm providing you. Like, right. And most often, I mean, there could be a situation where, like, someone say, like, because I live in Iowa, we're a very white state. I come across racists all the time. And I've even had nurses, here's the thing. I'm going to risk sounding like a stupid white person here, but I follow Instagram accounts that are like, empower Black nurses. Yes. We need our patients to look like our nurses. I don't think that means that if I have a Black patient that I'm assigning, I'm not going to be like, oh, you're a Black nurse, you'll talk. Maybe they don't get along. It's not right. Like, oh, hey, you guys all, like, those racist attitudes need to die. But I think that we need to empower people to speak out. You have to be careful with patients because, your patient could be like watching Fox News and like preaching some horrible shit. And in that case, I say, hey, I don't feel that way. I really don't want to talk about that. Like, let's just stick to your medical care. Yes. But if I see someone like treating someone like shit, I think that my privilege God, I'm going different directions here. My privilege requires that if I think someone, if they don't have a trauma, if there's not something legitimate happening there, that I don't get to, you're not going to get your racism catered to. It's the same way I've had patients say that they don't want the fat nurse back. They don't want the nurse with the accent back. They don't even want the float nurse back. They may be white, English speaking, just like the patient, but like, I'm sorry, you don't get to. I think that there's a fine line, but I have yet to meet someone who's like, I was beat up by a black man that looked like you. I have PTSD for, like, that's not what's happening. People are just like, oh, you're my nurse? I don't cater to that shit. You're Indian, Mexican, white, Irish, Filipino. All those nurses are capable nurses. They're all licensed nurses. I'm sorry. I have a hard time with that. I
hear you. I mean, I think it's important to be said, just because, I mean, there is an actual difference, right? Like, if a female patient wants a female nurse, that's a legitimate claim, right? Like, of course, it makes sense. But when you talking about race, you talking about if one of the nurses has a hijab on or a headscarf on and is saying,
that's like, she's not cathing you with her hijab.
Yeah,
like, right? You don't have to touch it. You don't have to believe in it.
In fact, it'd be best if you wouldn't touch it, right?
Right.
Like, exactly.
Exactly. Don't ask, like, what's that? What are you? Why do you, like, it's cool if you have a patient that, like, wants to learn and understand. I'm not saying, like, cut those patients off. But I've even had patients that say to me, like, are you old enough to be holding my urinal? Yeah. Well, you know what? I fucking am. So do you need me to do it? Do you want me to spend 10 minutes looking for a dude that can help you? Because, like, he's busy and you can wait a while. You can hold your black. Like, I don't have tolerance for the racism shit. But it's the same way with, like I said, the whole I don't want a fat nurse. Well, really? Because she's a really good nurse. She knows these meds better than anyone. I go to bat for those people. I might not say, like, you're a racist and you're an asshole, but I might be thinking it.
You got to, like, but at some point you got to be like, look, this is just, it's inappropriate. Can we not do that? We can't do this. Like, you have to put your foot down at some point, right? At some point you got to put your foot down. But you also
have to get to the root of it. Like, is it because that particular nurse treated them badly and they don't want that nurse back, and it has nothing to do with race? They just happen to have different races. But, you know.
Oh, yeah, because that shit
race
happens
is
all the time.
Race is a fucking social construct. It does. Yeah. And, you know, the same way that, like, white men are perceived as doctors, as white females are perceived as nurses, black females, black males are perceived as whatever, support staff. Like, can you call my nurse? I am your nurse.
Yes,
like,
exactly.
You know, so that shit I don't have tolerance for. However, you know, I like to think of myself as being one of those people that any kind of injustice, I'd hope that I'd have the balls to speak up and say, like, we don't do that here. Like, we don't play that shit here. Like, we don't support those isms, whatever they are. But I think I see it most with racism because, like I said, I live in a primarily white, red state. Yeah. So it happens.
Living in a primarily white, red state, with the presidential election going on, you don't have to say if you're for Trump or for the Republican Party, but
I can decidedly say that I would get arrested if I told you my actual thoughts on Trump. So
okay,
I try not to go super political on the podcast, even though I think politics and healthcare are very tightly intertwined. I try not to get super political because I don't want to polarize my listeners who would otherwise benefit from my information.
Makes sense.
But
I don't take those heeds on this podcast. So please go away.
I'm a bleeding liberal, socialist, almost Marxist, like
like all the way on the left. You're all the way.
Kind of. I believe in. I'm not a libertarian, but I do believe in personal liberties. But I also believe that some people are so rooted in what they think is right and wrong that they would happily infringe upon the rights of others. And so I feel like, as a person with privilege, I think that if I don't do my part to say, like, no, your Asian nurse with the accent was totally right, and what she told you is totally true because her accent does not affect the way her brain works. Right. In fact, like, you know, I've said it once to a patient who was being very verbally aggressive, and I said, they were like, well, I can't understand shit she's saying. Sorry, I shouldn't do the accent. I shouldn't mock people, but like, I can't, they say like, I can't understand her. It's like, well, did you say, hey, I'm having trouble understanding you? Like, can you look at me when you're speaking? Or like, can you use a different word? These are just people that are like, yeah, no, I'm not going to try. It's like, well, they might have a hard time understanding you because guess what? They're so fucking smart that they're nursing in a language that's not their native tongue.
Exactly.
Could you learn Japanese and go be a nurse in Japan? No.
Yes.
Well, your Japanese is shitty. What you perceive as shitty English is actually really fucking good English because it's not their first language. Right. So, I mean, I'm never going to get aggressive with a patient like that. But if somebody's being an asshole about it and the nurse is not doing anything wrong, I'm going to say that.
It's just not allowed.
I had a patient that was like, she had a clogged feeding tube and she was trying to unclog it. She had all the right supplies. She had warm water. She had a small syringe. She had the clog busting shit that we use.
Yeah.
And the family, I walked in and she had been working on it for a while trying to get the clog out. I walked in and just by chance, I was able to get the clog out in like 30 seconds. And the patient family was like, oh, you fixed it? She's been working on it. And I said, well, I mean, she did all the right things. She has all the right supplies. And they were like, oh.
Yeah, it just takes some time, boo-boo. It's a clog. Sometimes it was dissolving. Exactly.
If your drain is clogged and the Drano doesn't work the first time, are you like,
oh my God, right?
Sue the company. No, like give it a second. But I had to say, like, she's doing everything right. She just loosened the jar lid for me. That's all. And they were like, oh, really? So go to bat for those people. Like, instill those, especially if you are white and you're in a white community and you have white patients and our patients are old as shit. Sometimes they have different ideas, but you know what? I didn't know how to use a cell phone when I was a kid. I learned.
Exactly.
You can adapt. You can learn.
But I like to put my guests on the hot seat. So I have to ask, is there anyone that you have endorsed that you have your eye on from the Democratic side? Or is that something you don't mention?
So It's not that I don't want to talk about it. It's that I haven't made up my mind yet. The thing is that politicians, as much as I might like a politician, that's still a politician. I might feel really strongly about their stance on, civil liberties and personal freedoms, but maybe I think they're kind of a warmonger, so it's hard for me to make a decision at this point. I wouldn't abstain from talking about my decision. I just haven't made one yet. I just don't know. That makes sense.
On that same, I just want to know, because for me, my biggest issue is Medicare for all. I don't know how much you know about Medicare for all versus our current and health insurance versus Obamacare. Like, I don't know how much you know about that. A fair amount. I love that stuff. Like, I knee deep in policy. I love all that stuff. Do you think that as a nurse, as a healthcare professional, do you think that Medicare for all, a single payer system for the U.S., is a good way to go? Or do you think we need private healthcare insurance? Do you like the current situation we have right now? I think that privatized healthcare, I have to adjust my chair. I think privatized healthcare and privatized health insurance is literally killing people. It is literally causing people to ration their insulin, skip their meds, avoid having necessary procedures. That's also, I think that a lot of these things are so intertwined that it's hard to piece them apart. I think people not having health care is why emergency departments are overburdened, which is why people are not getting the emergency care that they need. Our emergency room at my hospital holds like 160 some people. I might be off on that number. The other night, they had 250 people in their waiting room. They have people that are intubated, ventilated, people that don't have emergencies. They have to see them all because we're essentially a state hospital. We can't turn people away. Yes. But also, our governor has repeatedly turned down Medicaid expansion, has cut mental health services. So now you see more people in emergency departments because they don't have health. They don't have preventative health care. They don't have prescription management. They can't catch shit early. So they come in when the cancer is like busting through their skin because they're scared because they have. I love that when you say that, because I don't think people understand it. And a lot of people, outside of how much it's going to cost, a lot of people say once we have Medicare for all, the waiting lines are going to be forever long. But they don't understand that. They're long now. And the reason say, like, I don't want to wait 50 years for an MRI. Motherfucker, I can't even get into my primary physician for 3 months. Who do you think's not waiting? See, and that's the thing, because people don't understand that when people don't have health insurance.
Mm-mm.
They don't go in for the stuff that they could prevent. They don't go in to stop the bleeding, right? They go in at the absolute last minute when it's like shit
They
hits
go
the
in
fan.
when their leg is necrotic and they're in
Exactly.
DKA, and they tell you that they haven't been able to afford their insulin for 4.5 months, and you're like, well, no wonder.
Of course.
So I am for socialized medicine. I think that all of the arguments, the typical knee-jerk reactions that people have are either already happening or are just simply not true. And I think if we look at other industrialized, successful, financially successful nations with happy people, you will find that, like I saw a meme the other day that both made me laugh and made me really angry. It said something like, it was like a pro-gun post, and it said like,
yes.
well, I own a gun because if I ever need to put my kid on a flight for a kidney transplant, no government is going to tell me I can't. And then the bottom underneath, somebody had replied, so you're saying you would hijack an airplane to go to a country with socialist medicine so that your child doesn't die? Okay.
Right?
You go to a socialist country if the government fails, but you won't be a socialist. And here's the thing. We're already a socialist democracy, essentially. Like my partner right now is in library science school and he works in a public library. The public library now has become like, libraries are hiring social workers and librarians are functioning as social workers because we have mental illness that leads to homelessness. People don't have resources. The libraries essentially become a hub for people that have mental health issues, and they're constantly dealing with these things. And they're not healthcare
really a
providers.
Librarian?
He works at a library. He's a librarian's assistant, and he is in grad school for to be a librarian. And people are like, "Oh, when you shelve books?" No, we're talking. We have the public library system, and I don't want to get off into that, but it's similar to nursing. Like there's 800,000 different kinds of librarian you could be. Same way with nurse. You can be a clinic nurse. You can be a bedside nurse. You can be a nurse practitioner. You can be a research nurse. It's the same way. You can be an archival librarian. You could be public school. You could be public service. I mean. So I guess the point that I'm making is that these industries that we don't think of as healthcare industries are being forced to do healthcare-like things because people don't have anywhere to go. Like they closed all of our mental health facilities. Yeah. And so you have people that have mental illness that are now homeless, incarcerated because
exactly.
I've taken care of patients who had to divorce their spouses of decades because they needed health care and they couldn't get it with their spouse's income. There's a woman that I interviewed here in my state. Her husband lives in Illinois because the only place her insurance company would cover for her to receive skilled care was like 3 hours away. So she doesn't see the family anymore. And they can't afford to come see her every day. Who drives 3 hours, 6 hours a day to see their family member? So all because she couldn't afford, like she wouldn't even have insulin or her incontinence briefs covered if she didn't do that. It's like, what the fuck are we putting people through over some political argument?
That's
because people are like, I earned my money, it's mine. I don't care if you die.
That's crazy. And the cherry on top, the kicker is that it will end up being financially better for the country, right? Depending on how much you make each year is different for each like individual, but for the country, Medicare for All does.
And it doesn't hurt people. Like, people say like, well, I'm not paying in so that I can pay for your abortion or your birth or your aesthetic, your nasal septum deviation repair. Like, people are like, I shouldn't have to pay for that. Okay, well, you're required by the state to have health or car insurance. If you don't insure your car, there are consequences for that. Exactly. And you're paying into a pool of money that's used to pay out other people's accidents. But it works because it all balances. The problem is when you have these companies that are making money off of denying claims and off of pushing pharmaceuticals. So the system, it's not just going to be like, oh, let's get socialized medicine. It'll be fine. Because a lot of people are going to have to let go of some really big bank accounts at the expenses of poor people, essentially. And, people say like, oh, well, they don't take care of themselves. They deserve to have health problems. They don't. You know what? I could go right now and buy a bag of Cheetos and a Pepsi and have more quantity of food than if I go and try to buy organic vegetables. Right. Our system is set up that in every direction, people are kind of screwed, especially if you don't have resources. If you have resources, Cool. You were born to a family that you weren't born into poverty, or you were able to work your way out of poverty or whatever. But there are some people that it's like they can't get ahead. It's like, you skip your insulin because you don't have your $200 or whatever it is for your insulin. Now you've got $150,000 medical bill because you went into the hospital with a blood sugar of 750.
Exactly.
Exactly. Who are we helping?
Who's
are we
winning?
saving?
Yeah, exactly. Who's winning outside of the pharmaceutical company that's making, insane amount of money on this drug that they just increased the price by 110%.
It's like there are
crazy.
Yeah, there are politicians in my state that want to take healthcare away from nurses in my facility. They want to lessen our coverage, make us pay for it.
Ridiculous.
It's like
Absolutely
I'm exposed to so much risk, disease, violence, injury. I've been injured multiple times, and you're telling me you want me to do this while paying for my own fucking health. Like, you don't even want your healthcare workers to have healthcare. Like, what does that say about the system? Like, you only want the people who can afford to pay out the ass to have healthcare, so that, whatever medical company, insurance company can make a $3 trillion profit.
Go fuck yourself.
Yeah. If we had that many cats, we'd be pathologized and put away. You have that many dollars and you're exalted as a fucking genius.
Right. But
sorry, I got real opinionated there.
Okay, so you just, I have so many things that I want to talk to you about. I'm so sorry. Okay.
Hold on, I accidentally pulled my headphones out. I'm always the one doing the interviewing, so this is kind of fun. I'm like, oh.
No, I really appreciate this. Oh, so I know you mentioned abortion, but I don't want to talk about your personal views on abortion. I just did a story on this nurse in Vermont. I think it was the University of Vermont Medical Center. Mm-hmm. Let me just give you a real quick briefing of the story. She comes into work, but when she got the job initially, she told her a nursing manager, I don't want to be a part of any abortions. I don't believe in it for religious reasons. She gets to work. She's told that her assignment that day is that she's going to help someone with a miscarriage. She goes into the operating room. I'm sorry. She's going to help someone who just got a miscarriage. She goes into the operating room and she finds out that she's actually the OR nurse to help with an abortion. She ends up filing a suit. She gets she gets let go. She files a suit. Now she's suing University of Vermont. The University of Vermont Medical Center says they needed her to stay there because she was the only nurse that could help, that was able to, that had the education to help in that procedure. I want to know, you can talk about that specific situation because it's very convoluted and you can go both ways on that one, but do you think it should be required that nurses that work in L&D, that nurses that work in these emergency situations be required to be a part of an abortion procedure if it's necessary? Or do you think that nurses shouldn't be, like, you should be able to choose what you can and can't do based on religious or personal beliefs?
So this is definitely a slippery slope, and I think that there are always gray areas. However, I think that if you are a healthcare professional that is working in labor and delivery, obstetrics, women's health, whatever that looks like, first of all, I like to say this. I don't know the case very well, just from what you've told me. Like, yes. I don't know the story. But here's the thing. So if this is where I get into gray areas. First of all, I think abortion should be legal, available upon demand, covered by insurance, and not the business of any other motherfucking person besides that woman, the people she chooses to invite into her decision, and her physician.
Exactly.
Or nurse practitioner or whatever. I think that is my baseline belief system, because I think that when we are able to control the number and timing of our children, regardless of whether that's I want to have 10 kids or I want to have no kids, I think that we as women become secondary citizens when we cannot control our bodily autonomy. There's so much manipulation and abuse of women that occurs that being able to control our fertility is safe, effective, and there's all these myths that need to die that, like, here, let me get back to this. So she miscarried, needed to go into the OR. So what happens then is the miscarriage, from what it sounds like to me, is already in progress. And what this woman needs is called a DNC, a dilation and curettage, where essentially what they do is they dilate the cervix, they go in with vacuum suction or a curette, which is like a little tiny instrument that's used to scrape things out, and we scrape out the remaining products of conception within that uterus. The reason that we do this is because if this woman is miscarrying, she's already miscarried. She's already in which miscarriage is spontaneous abortion. I hate the language around this. People are like, abortion. Yeah, guess what? When you miscarry, your body is spontaneously aborting. Should not be the like polarized term. Women are not at fault. Women miscarry all the time. For some women, it's devastating. So we shouldn't minimize this.
Yeah.
But if you need a D&C, you need that D&C so that tissue doesn't become necrotic inside your uterus, make you septic, and kill you. So I would argue that needing a D&C during or after miscarriage is not technically an abortion. That's the first thing I would say. The second thing I would say is, nurses all the time are faced with things that conflict with their own, like we talked about. I don't want to code your 90-year-old grandma who weighs 86 pounds. That's a huge ethical issue for me. But guess what? When I signed up for this, I signed up that I would give people bodily autonomy. And if grandma wanted to be full code and she told you she wanted to be full code, well, by God, she is a fucking full code. And I may not like it, but I have to do it. If I have beliefs against giving blood, I may, anywhere you work, whether it's pediatrics, oncology, respiratory, ICU, general medicine, you are going to come across a situation where you feel your ethics are being violated. Now, if your ethics are so strong that you know that you could never, ever perform or assist with a D&C or an abortion, regardless of the circumstances around it, then I think that is not the industry for you. If you want to only work with moms that are giving birth and are happy about it, work in a birthing center. Work in a space where you don't have to handle the other side of things. But I'm sorry, if I come in and I say, hey, I'm having this problem, I need to be on birth control because I have really heavy periods and it's affecting my quality of life and pain and my job, like it's a quality of life thing. If your fucking balls hurt 1 week a month, a doctor would do something about it. Like there'd be something, but
you better believe they would.
Exactly.
You better believe.
So I think that there's always going to be that time when something is going to challenge your belief system. But if it is an expectation that is going to happen potentially over and over again in your job, find a different job. There's 8 trillion nursing jobs. You may want, like I said, you may want to be an L&D nurse, but maybe the hospital setting is not right for you if you're going to be faced with things. Because here's the thing. We have to take into account, like you said, she was the only nurse with the education and experience to do it. So now by your refusal, you've put that patient in a situation where they're either having someone who's not competent to do that care, doing that care, or the worst case scenario is they're not going to get that care, which at all. So I think that this is a slippery slope, but I would say no. When you are caring for someone else, I don't give a shit if you don't feel comfortable trimming their toenails. If they ask you to trim their toenails, that's what they need. That's what you need to do. So I think that if you're picky about who you want to take care of and how you want to take care of them, maybe find a situation where somebody's life and well-being isn't going to rely on your morals. That's what I say to that.
Adrianne, that was so well said. Holy Jesus Lord. Maybe you should go into politics.
I worked in women's healthcare from 18 to 24. They taught me that the patient is at the center of care. So like, for example, the simplest respect, when a woman goes in for a gynecological appointment, we put our feet up in the stirrups, we scoot our ass down to the end of the table, and you feel like you're the most vulnerable you've ever been in your whole life. As a doctor, you don't walk in and talk to the woman who's laying down with her feet up. You meet that woman face to face with her sitting up, with her covered, and then you say, are you ready to begin the exam? You don't disempower people from the moment they walk in the door. You want them to be empowered to take care of themselves, but you don't want to empower them when they're under your care. Those are contradictory statements.
It's crazy.
Yeah. So yeah, that's a really long answer, but I think no, you got to set your personal beliefs at the door. I may not believe in giving this patient Mountain Dew with their pills. Like I may think they need water, but guess what? That's not what they want, and they're alert oriented and their own guardian.
So they got to do what they got to do, and we can't stop them. We can't stop them.
Nope.
I love that. So Adrianne, I've stolen so much of your time, and goddamn it, I want to do this again because you're so good at it. But before I let you go, I want to know more Adrianne specific things. Okay. So we know why you started the podcast, right? But I want to know just what are the what are the things that you are currently obsessed with outside of it could be nursing related. It doesn't have to be nursing related, but I want to know, like, is it Netflix? Are you catching yourself up on Game of Thrones? Like, what is Adrianne's me time? What is me time for Adrianne right now?
Me time for Adrianne is like dinking around at my desk listening to podcasts.
Okay.
My list of favorite podcasts is so long and oppressive. I can't even name a few of them because I'm like, oh, but then there's that one. Oh, but then this one is good too. And actually, this is not only how I was inspired to want to do a podcast, but I'm like a junkie for podcasts. I used to be the NPR person, like all the time. NPR is on in the car, in my earbuds, in the house. But I found that wasn't good for my mental health. I still pay attention to the news. I have a responsibility, and not to just be like, oh, I don't have to pay attention to that because it doesn't affect me. Like, I try to be very conscious of that. Again, that's my privilege talking of like, oh, I have the ability to not think about war-torn countries because I don't live there. But does that mean that I shouldn't give a shit about our foreign policy? No. So I like NPR, but I found that it was hurting my mental health. So podcasts are the way to go. If I'm home alone, there's a podcast on either in my earbud or on the Siri, or not Siri, Alexa or whatever. So yeah, that's it. I like listening to things because then I can do other stuff.
Give me at least one or two podcasts right now. Give me something tangible.
I'll tell you the podcast that started me wanting to do a podcast. And that's a podcast called Weird Medicine. And every day, yes, it's my favorite podcast. It's been on for a long time. Some of it is behind a paywall now because they're like a Sirius XM show, and they do the podcast. I've literally been listening to this podcast since I started nursing school. I had a 30-minute commute one way to school up the interstate. It was like a 30 to 40-minute show. And I tell you something, there's stuff that I know about that people are like, how the fuck do you know that? Where did you get that? They didn't teach that in nursing school. Nope, I heard that on a podcast from a doctor. And their Weird Medicine is completely uncensored. So they get all the questions about poop and testicles and erectile dysfunction and, fetishes. And so it's not all sexual in nature, but it's people calling up and being like, I have this weird discharge and I'm afraid to go to the doctor. It was incredibly inspiring to me because I was like, this guy is saying whatever the fuck he wants. He's not violating HIPAA. He's not discrediting himself as a physician. If anything else, he's catering to people. He's providing a service to people that otherwise wouldn't have these answers or would be afraid to talk to their, you're facing your doctor who's like, whoever they are. You don't feel comfortable being like, I've had a hard time getting a boner. Like, it's hard to do that. They talk about all that. They just have those conversations. Theirs is like a call-in show. Like, they take like calls from people. But that was the thing that made me go, oh, is there one of these for nurses? Like, is there a weird nursing? So yeah, that's kind of where, and to give you one other little tidbit, long before I started listening to podcasts, before I was making a podcast, I had a radio show on the local college station. And
stop it. You were born to do this, Adrianne. You were born
I worked at a call center. I had a radio show. But the thing is, the radio show, it was called Little Village Live. It's on iTunes. You can find all my old episodes. Here in town, the local like arts magazine, Little Village, it's a free publication. I got involved with them doing photography, and because I was going to shows. I was in college. I was going to shows. I was at the bars. I was taking pictures. They were good. So then they started letting me do more and more stuff. So I started blogging for them, and then I found out that their live music show was about to be without a host. So I stepped up. So essentially, 1 hour a week in the middle of the week, I would go into this public art space on campus. I would have booked a band. The band will come in, play a couple songs, answer a couple questions, play a couple songs, answer, so on and so forth for the hour. It was all different genres, touring bands, local bands. And I loved it so much that I was like, oh, radio. I want to be fuck nursing. I want to be a radio. And then I went through nursing school and I said, oh, I can get audio software and I can watch YouTube videos and learn how to edit, and I can get on the horn and I can say whatever I want because I don't have a sponsor or a publishing company or a studio to answer to. So, so that's one, Weird Medicine. And then the other one that's my political comedy show that I listen to is Throwing Shade.
Throwing shade? I'm
Brian
gonna have
Safi
to.
and Aaron Gibson. It's so first of all, it's a little manic at times, but I love it because they're funny, they're opinionated. Aaron Gibson is like, she is the person that I most relate to in the world because she'll be like, this fucking what? This is this injustice, like these things that are happening, like this is horseshit. And I'm like, fucking preach it, sister. Like,
Yes.
and then Brian Safi is like a homosexual Lebanese male, and he, and they talk about everything: women's issues, civil rights, gay issues, healthcare, stupid politicians. Love it. Like if I see that there's a new episode, I'm on it. I also watch YouTube like TV, and that's all I'll say. I won't get into that because that's like a whole other episode of like the YouTube channels I follow.
Yeah. Oh, I love it. Oh, Adrian, I love it. I'm gonna have to look at. You said throwing shade.
Throwing shade.
I'm gonna have to look that up. I'm gonna have to look that up.
If you're a conservative, racist, homophobic asshole, you won't like it. But if you're down with empowerment and identifying shit that's fucked up that we need to take action on, that's the place to go.
I love it. I love it. Adrian, please, Nursing Uncensored, please tell them where they can find you, how they can find you, all of that stuff. Plug away, please.
If you're not a podcast aficionado, you can just go to nursinguncensored.com. You can play it right in the browser. You can download it from the browser. I've got the blog and the episodes. Also, we're on every podcasting, I say we, the royal we. I'm on every podcasting platform: iTunes, Spotify, Spreaker, Stitcher, Podbean, all of them. So you can find me just about anywhere.
Cool beans.
We have 68 episodes and just reached 150,000 downloads. So,
are you shitting me?
I'm not shitting you. The hardest part has been now that people are emailing me for advice and questions, and I'm like, I gotta go work. I got an appointment. Oh, I don't have time to answer this email. So now it's a matter of like trying to keep up. And so I've just decided that every question that I get from a listener, if I can answer it, I'm just going to do it as either a blog post or an episode, because so if you're listening and I haven't emailed you back yet, I'm tired.
That is a hardcore, intense, lengthy way to explain and answer questions.
Sometimes it can be a 5-minute episode. Sometimes it can be a 200-word blog post.
Right.
Sometimes it's just me getting on Instagram and being like, oh yeah, Instagram. I'm on Instagram. I'm on Facebook. You can find me just.
Her Instagram is going to be on the screen the entire time for those who are watching it on YouTube. And for those who are not watching it on YouTube, it is Nursing Uncensored? Nursing
Uncensored. Yeah.
Keep things simple. I like it.
Yeah, keep it simple. You can also find me, Adrianne Behning. You can search me, and my web presence is there. It's there.
So I only say this when it's true, you guys, but it is very much true. I slid into Adrian's DMs, and she answered. So, like she said, if she hasn't answered you, it's because she's working on it. But she will answer you. So go connect with her. Go look her up. Go listen to her stuff. It is legit. I mean, when she says uncensored, she gets into the nitty gritty, the dirty details, ladies and gentlemen. I love it. I love it.
Everything from poop to professionalism.
That's right. You got to have it all. Adrian, thank you so much. I really appreciate this. We should do this more often. You get me going, girl. You get me going.
Yeah, let's. We'll have to. Maybe I'll have to jump in on a couple episodes where you're talking about those topics where you need somebody with a really strong opinion.
Oh, please and thank you. You know I'm gonna need all of that.
Awesome. Well, thanks to everybody who listened and watched. This was a lot of fun. It's like I said, it's cool being on the other side of the interview for once.
Cool beans. All right, bye-bye, y'all.